This conference will now be recorded.
Hello, good afternoon, everyone. Today's our topic is abdominal aortic aneurysms. So, what do you mean? What is the definition of aneurysm? So, dilatation of localized segments of the arterial system are called as aneurysms when there is a more than 50% increase in the diameter of the vessel. If it is less than 50%, then they are termed as ectatic. That is the main difference. So, if you want to say it is an aneurysm, then the diameter, increase in diameter should be more than 50% of the arterial vessel. So how will you classify the aneurysms? So depending upon the presence of layers of the arterial wall, they are true and false. In true aneurysm, there will be all the involvement of all the three layers, intima, media, and adventitia in the aneurysmal wall sac. So false is the presence of only single layer of fibrous tissue as a content in the wall of the aneurysmal wall. That is aneurysmal sac wall. So depending upon the morphology, so shape. So it is fusiform when it is circumferential dilatation. It is called as saccular when it is focal outpouching type. So depending upon the etiology, so most common cause for aneurysms is atheromatous, so atherosclerosis. So other one is the mycotic. So by that name, mycotic means usually we will think that it is a fungal infection, but here it is mycotic means bacterial infection, that is vegetations. So third one is the collagen disorders. Fourth one is the traumatic. So best example of traumatic aneurysm is a false aneurysm. So it will contain only the single layer of the fibrous tissue. So other atheromatous aneurysms or mycotic aneurysms or collagen causing aneurysms are all the examples of true aneurysms. So aneurysms may occur in the aorta or iliac vessels or popliteal vessels, femoral vessels, subclavian, axillary, carotid, cerebral, mesenteric, splenic, and renal arteries and their branches. So the majority are true fusiform atherosclerotic aneurysms. So common presentation of aneurysms are the true aneurysms with fusiform, that is circumferentially involved. So the incidence of abdominal, today's our main topic is the abdominal aortic aneurysm, which may be given as a essay question for. So based upon lot screening studies is estimated to range from 3 to 10% incidence. So abdominal aortic aneurysms, it is by far the most common of large vessel aneurysm and is found in 2% of the population at autopsy. 95% have associated atheromatous degeneration. 95 most common site of abdominal aortic aneurysm is below the origin of the renal arteries from the abdominal aorta. That is accounts for 95%. Because I think all you know the branches of the abdominal aorta, no? Hello? Can anyone tell what are the branches of abdominal aorta? Hello? So there are main 3 anterior branches, 2 posterior branches, and terminal branches and lateral branches. So what are the major anterior branches from the abdominal aorta? First one is the celiac trunk. Second one is the superior mesenteric artery. Next one is the inferior mesenteric artery. So between the T12 and, because the abdominal aorta usually starts from T12 and L4. So celiac trunk arises from the between the T12 and L1. So superior mesenteric between L1 and L2, whereas inferior mesenteric origin from between in at the level of L3. So at the level of L4, the abdominal aorta terminates or bifurcates into two common iliac arteries. Again, left, right common iliac arteries again divided into external and internal iliac arteries. So these are the three main anterior branches, whereas the two posterior branches are the lumbar, four pairs of lumbar arteries and the median sacral artery. These are the two posterior branches. So as I said earlier, terminal branches are the two common, right and left iliac arteries. So lateral branches are the inferior phrenic artery, then renal artery, middle adrenal artery, then gonadal arteries. These four are the lateral branches. So what are all the risk factors for the both development as well as expansion, and also which leads to rupture of an aneurysm? So first you will look at the risk factors which are responsible for the aneurysmal development. So most common is the smoking, tobacco use. Second one is the familial history of hypercholesterolemia. Next one is because which leads to atherosclerosis of the vessels. So hypertension. And again, an aortic aneurysmal development is more common seen in male gender with family history especially. Whereas aneurysmal expansion, so enlargement, so as age advances, advanced age itself is one of the risk factor for the expansion. Next one is the severe cardiac disease. Next one is the any previous stroke, attacks of strokes, and again tobacco usage. The other one is the cardiac or renal transplantation. So whereas coming to the risk factors responsible for rupture of aneurysm. So here rupture is more common in female genders when compared to the male gender, whereas development is more common in the male genders. So again decreased forced expiratory volume, so which indicates that there is a presence of obstructive respiratory disease, that is called as COPD. Then one is the larger initial abdominal aorta diameter and higher mean blood pressure and current continuation of the tobacco usage. But here, what is the important? So an amount or number of packages of cigarettes are not important. The important is one is the length of the time of smoking. The next one is the cardiac or the renal transplantation. Next one is the critical wall stress and wall strength relationship. As the wall of the vessel is thicker, so the for rupture is the chances of rupture of aneurysm is decreased. So predicting the behavior of an aneurysm over time is difficult, but the most widely adopted risk calculation of rupture of risk is maximal cross-section aneurysm diameter. That is the most important. So how will you estimate the annual rupture risk? So depending upon the diameter, what is the percentage of the risk for rupture? So if it is less than 4 centimeters, there is a 0 chances of rupture. So 4 to 5, it is 0.5 to 5. If it is 5 to 6, it is 3 to 15. So as the diameter of the abdominal aorta increases, there is a risk also increasing. for a rupture. So 7 to 8 centimeters, 6 to 7 centimeters, it is 10 to 20. 7 to 8, it is 20 to 40. Usually, when you will go for surgical repair of an aneurysm is 5 centimeters. So usually up to 5 to 5.5 centimeters you can manage. So after following serial assessment of CT, all those things, you should strictly follow the patient in order to estimate the expansion of the aneurysm and also risk factors or impending rupture of the aneurysm. That is the important from this slide. So in addition, an observational study suggested that even broadly accepted estimates of risk may overstate the rupture rates of untreated. So as untreated abdominal aortic aneurysms are more prone for ruptures. So in patients deemed medically unfit for elective surgical repair, then the risk of death from non-aneurysm related causes exceeded the risk of death from the rupture. So overall, untreated cases and also medically, because only the point is untreated abdominal aneurysms are more prone for rupture, which leads into death. So most clinicians do consider the rate of enlargement a risk factor for rupture. So a rate of growth of more than 5 mm in 6 months or more than 1 centimeter per year has been widely adopted as an indication for repair. So both size and also duration independent of aneurysmal size. So first one is depending upon the aneurysm size, and second one is rate of growth of the rate of enlargement of the aneurysm in a particular duration. So how will you diagnose a case? So abdominal aneurysms may be detected on physical examination as a palpable pulsatile mass, most commonly supra-umbilical and in the midline. This is the most common site where you look for abdominal aneurysms. So the location may be variable, however, depending upon the patient habitus also. It may, you cannot, if patient is obese, then you cannot appreciate or you cannot localize the palpable pulsatile mass. That is one. Then location may be variable. It not only, it is most commonly supraumbilical. It can occur in infraumbilical and lateral position also. So coming to the investigation. So how will you what are the choices of investigations to diagnose your condition? So ultrasound examination has been demonstrated to offer excellent sensitivity and specificity, but ultrasound is limited by the patient's habitus and bowel gas. So, but as it avoids the complications associated with invasive techniques like radiation or injection of contrast material. So, other than this, it is an excellent choice for screening, especially for screening of the patients. But ultrasound is not an ideal method for detecting a rupture. That is important. So it can detect a aneurysm, but it cannot predict the rupture. So it is unable to image all portions of the aortic wall and on the non-fasting status of emerging, because almost abdominal rupture of abdominal aortic aneurysms almost are the emergent cases. So we cannot do so, you cannot have the non-fasting status of a patient, so that is impossible to image all the portions of the aortic wall. So these patients are examined by further include the ideal image acquisition may be required as CT or MRI. So it has been estimated that ultrasound may fail to detect up to 50% of aneurysm ruptures. So computed tomography, it provides an excellent imaging of abdominal aortic aneurysm with greater reproducibility of diameter measurements than by the ultrasound. That is the major advantage of CT. Next, then it can have, particularly with the adjuvant use of iodinated contrast agents to perform CT angiography, provides a wealth of anatomic particle. So you can have the all detailed anatomic information about the aneurysm and predicting the rupture, and already ruptured aneurysms also can be made out. Another one is it can pick up the calcifications also, so which is main. So it detects vessel calcification, any presence of thrombus and concurrent arterial, any occlusive diseases, and permits multiplanar and three-dimensional reconstruction. Mainly CT helps or aids in the type of surgery preferred for the condition. So analysis for operative planning. So drawbacks of this CT includes the substantial radiation exposure, particularly in the setting of an serial examination, use of contrast media in a population with a high incidence of comorbid kidney diseases. So coming to the magnetic resonance imaging and magnetic resonance angiography. So both sensitivity is almost equal to the CT. So unlike CT, only the drawback is it cannot demonstrate the aortic wall calcification, so which may help in plan of surgery. So that is the only drawback with the MRI angiography. So although the study does not require the use of iodinated contrast material wherein magnetic resonance, but here we will use a gadolinium, so which has been associated with the development of nephrogenic fibrosis in patients with especially low glomerular filtration rate. Not all the patients. So how will you screen and surveillance recommend? What are the recommendations? So the Society for Vascular Surgery Committee charged with reviewing available data regarding screening made a strong recommendation for one-time screening of all men aged above 65 years and older, or men above 55 years and older with a history of abdominal aortic aneurysm, so 10 years. Then again, screening of women is also strongly recommended for those who are aged above 65 years and older with a family history and also a smoking history. So once an aneurysm has been detected, the Society for Vascular Surgery has recommended for the screening intervals as follows. So based upon the aneurysmal size, so maximum external aortic diameter and associated risk of rupture. So if the size is less than 2.6 centimeters, no further screening is recommended. If the aneurysmal size is between 2.6 to 2.9, then re-examination at 5 years interval. Then, if at all it is 3 to 3.4 centimeters, re-examination at 3 years interval. 3.5 to 4.4 centimeters at 1 year interval. 4.5 to 5.4 centimeters, then re-examination at 6 months. So, depending upon the size, you have to follow, you have to screen. So what is the medical therapy? So once an aneurysm has been diagnosed, the optimization of medical therapy serves as a dual purpose. First one is potentially to minimize the rate of aneurysmal expansion or rupture and to medically prepare for a potential repair. So many theories have been investigated in the search for effective medical treatment to prevent the progression of aortic aneurysms, leading to a recent editorial statement that the bottom line is that no drug can currently be recommended for the indication of already occurred aneurysm. So you cannot, so there is no drug available at present. So a highly anticipated randomized trial of, so in olden previous days they have used the doxycycline, which is an antibiotic, and also it is action of inhibitor of a matrix metalloproteinase activity. So not only failure to demonstrate the benefit, but they found that there is more increased aneurysmal enlargement primarily in the first 6 months of the follow-up. So currently, many continue to incorporate the beta blockade in an effort to control the blood pressure that may contribute to the harmful wall stress. But studies using the propranolol, that is alpha blocker, demonstrated the mixed results and the low patient complaints. So statin therapy. So that is HMG, that is 3-hydroxy 3-methyl glutaryl coenzyme A reductase inhibitor. So it is a rate limiting enzyme in the synthesis of the cholesterols. So statin therapy has been associated with the reduced rates of abdominal aortic aneurysm enlargement and is otherwise appropriate in a population with a high prevalence of a concurrent associated atherosclerotic diseases. So current tobacco use has been associated with an increased rate of aneurysm expansion both in males and the females. So smoking cessation may also yield benefits with regard to perioperative morbidity and mortality in the event that the aneurysm is ultimately requires a repair. So what are all the surgical modalities? So surgical treatment is generally recommended for aneurysms more than 5.5 centimeter in its maximal diameter. So those demonstrating more than 5 mm of growth in span of 6 months or more than 1 centimeter in span of 1 year also. And again morphologically saccular, because most common is fusiform. So if at all it is saccular, then rather than the typical fusiform, then ultimately it is an indication for a surgical treatment or surgical repair. So the presence of significant aneurysm related anxiety associated with awareness of that there is a presence of unrepaired aneurysm has also been cited as affecting quality of a patient's life and presenting a potential consideration in managing aneurysms below 5.5 centimeters in diameter. So what are the pre-operative evaluation? So the pre-operative evaluation of patients with abdominal aortic aneurysm compromises operative planning as well as the identification and management of associated medical comorbidities such as any coronary artery disease, any renal insufficiency, peripheral arterial occlusive diseases, diabetes mellitus, and obstructive lung disease. So as a routine full blood count, electrolytes, renal function test, liver function test, so coagulation test, and complete lipid profile estimation should be performed. So blood should be cross-matched if it is prior to surgery, because so at any time of surgery, so anything can happen. So there may be, so there can be more loss of blood also. So patient may go into a shock. So to prevent or to correct the shock, use the blood should be available. So many patients now have an anesthetic assessment and need for especially cardiac and the respiratory function test are decided at this time. So these are previous what I have said, the investigations all are the routine investigations. But if the patient had any cardiac problem or any obstructive lung disease, then after anesthetic assessment, then you will move on to the cardiac and respiratory function test. So cardiac, other than usually we'll do the ECG and chest radiographs, but other than those through investigations, echocardiography or isotope ventriculography or cardio pulmonary exercise testing and spirometry you will do according to the severity of the disease. So the morphology of the aneurysm is best assessed by the CT scan. So 75% of the endovascular repairs are usually done via the femoral arteries in the groin. So if lower limb pulses are absent, there may be associated arterial occlusive diseases that should be assessed by the duplex scanning initially. So further assessment with the CT, MRI or digital subtract angiography may be required. So careful evaluation of preoperative imaging is crucial in planning the type of repair. So anatomic variations such as the retroaortic renal vein or variant inferior vena cava or horseshoe kidney, so may significantly they can affect the selection of the surgical approach. So whether it is transperitoneal approach or retroperitoneal, so if not appreciated preoperatively, can lead to a dreaded complications. So what are all the techniques of open surgical repair of the abdominal aortic aneurysms? So open surgical repair of abdominal aortic aneurysm may be accomplished by either a transperitoneal or a retroperitoneal approach. So transperitoneal repair through a midline laparotomy incision is the most widely used approach to the usual infrarenal. So most common is the infrarenal aneurysms. So for all those infrarenal aneurysms, will best approach is the transperitoneal approach. So it offers a rapid exposure, excellent access to the renal and the iliac vessels, and the ability to fully examine the abdominal contents. So the infrarenal transperitoneal repair begins with the perioperative administration of antibiotic, typically a first generation of cephalosporins, and scrupulous skin preparation from the nipples to the thighs, mid thighs. So the patient is draped and the generous midline laparotomy incision is given from xiphoid to the pubic symphysis or just above the pubis. So this is a diagram where we are showing the exposure of requires so careful mobilization of the duodenum, which is distal to the ligament of trees to the patient's right side. So this is the most important point. So then the retroperitoneum may then be open to the level of the iliac bifurcation at the level of L4. So mobilization of the left renal vein facilitates the exposure and control of the neck of the aneurysm. So at this time, a decision should be made about the necessity of either to divide the left renal vein or its tributaries. So the iliac arteries may be exposed by careful dissection in the avascular anterior plane with attention to the preservation of the main ureter, which will typically cross at the level of the iliac bifurcation, and the pelvis sympathetics, which cross the bifurcation and proximal left common iliac artery. So once adequate dissection has been accomplished to permit proximal and distal control, then we will give the systemic heparin administration. Some clamps may be placed and the aneurysm sac is opened. So the sac should be opened just below the aneurysm neck, and the opening is extended along the right side of the anterior surface of the aneurysm, leaving the orifice of the inferior mesenteric artery in situ, that is the origin. So lumbar arteries and the middle median sacral artery may be ligated from within the sac to prevent the back bleeding. So an inferior mesenteric artery with brisk pulsatile back bleeding, or one that is chronically occluded, which often occurs in aneurysms, may be safely overseen. So they can be safely stitched, they can be sutured at its origin. So if at all there is a poor back bleeding, which suggests that it is an inadequate collateralization and is an indication for reimplantation of the inferior mesenteric artery into either a main graft or a left iliac limb. So once back bleeding can be controlled, the proximal anastomosis may be done. So typically in an end-to-end running fashion using the non-absorbable monofilament sutures such as proline, and an approximately sized woven or knitted polyester graft can be done. So an aneurysm terminating at or before the aortic bifurcation may be repaired with a simple tube graft as shown in the figure. So whereas involvement of the iliac vessels may necessitate a bifurcated graft and distal anastomosis to either the iliac or the femoral arteries. So once the proximal anastomosis is complete, so it should be examined by placing a second clamp below the anastomosis and carefully removing the proximal clamp. So without doing this step, if you release the proximal clamp, then there may be a heavy bleeding and patient may go into a shock. So any areas of bleeding may be readily addressed with the repair sutures at this time before immobilization of the graft by the distal anastomosis. So before doing the distal anastomosis, you should be hemostatically, patient should be stable and hemostasis should be secure. So before completion of the distal anastomosis, the distal iliac or the femoral vessel should sequentially be permitted to back bleed to flush out any remaining thrombus or the atherosclerotic debris. So the proximal clamp briefly removed to flush the graft, and the graft flushed with heparinized saline. So the proximal and distal clamps may then be removed. So it is imperative that the surgical and anesthesia teams communicate well during this process, as clamping and unclamping of the aorta produces a profound hemodynamic effects. So the patient should be well resuscitated before unclamping, as this act is frequently attended by a significant and immediate hypotension. So sodium bicarbonate to counteract the administration of sodium bicarbonate to counteract the acidosis, and the use of vasopressors to improve the blood pressures may be required. So the inferior mesenteric artery may be reimplanted at this time if necessary, most commonly as a chiral patch. So if hemostasis appears to be adequate at all anastomosis and the patient is normotensive, then you can give the antagonist for a heparin, that is the protamine sulfate. It can be administered at 0.5 to 1 mg of protamine sulfate per 100 units of the heparin is given. So once aortic replacement has been accomplished, then attention should be turned to graft coverage, because you have to definitely cover the graft in order to prevent of the contamination of the abdominal contents. So the aneurysm sac and retroperitoneum may be approximated over the graft as shown in the figure with to effectively exclude the abdominal contents, and in particular the third position of the duodenum, which typically rests just anterior to the proximal and infrarenal suture line. So that is the main important. You should cover the graft. So the abdominal, if present groin, so because if you are feeling difficulty, then you can extend the incision in inguinal also. So if any groin incisions there, it can be closed meticulously because hernias occur relatively frequently after open aneurysmography. So wound breakdown, particularly at the groin, can be costly and difficult for the patient and significantly increases the risk of graft infections. That is most important. So the retroperitoneal approach is thought by some to reduce the main physiological stress on the patient and to result in fewer post-operative pulmonary, especially pulmonary complications, and as well as the post-operative reduction of the post-operative ileus. So persistent postoperative pain, flank wall laxity, and hernia have been described, complicating the retroperitoneal approach. And some investigators have reported some frequent occurrence of these complications with use of the retroperitoneal technique. So with regard to the operative exposure, the retroperitoneal approach does offer greater access to the visceral segment of the abdominal aorta and can be either where required by the thoracic extension of the incision and exposure with or without division of the diaphragm. So these are the positions. How will you place the patient in retroperitoneal approach? So a retroperitoneal aortic exposure may be accomplished with a patient in a modified right lateral decubitus position with the thorax. Only thorax is rotated, but hips relatively flat to permit access to the both groins. So a curvilinear incision is made from the costal margin to below the umbilicus. Depending on the extent of the exposure, the surgeon is required and the patient's habitus. So the retroperitoneal plane may be entered at the lateral border of the rectus sheath. So the rectus abdominis may be reflected either medially or laterally. So some surgeons, they prefer to do lateral reflection as this may result in less difficulty with post-operative body wall laxity. So care is taken to avoid the entering the peritoneum. Much of the initial portion of this dissection may be carried out bluntly with the aid of a tonsil sponge or a Kelly's forceps. So the abdominal contents enveloped in peritoneum may be swept medially. The ureter will be visualized and swept medially. So it is a white, pearly, glistening structure. So the left are with peristalsis, that is the identification of the ureter, identification points of the ureter. So the left kidney may be either elevated or left in place, that is in situ, in the original position. So proximally, the spleen is carefully mobilized. So carefully mobilized within its peritoneal covering to expose the underside of the diaphragm. So the fibers of the left crest of the diaphragm when divided exposes the supraceliac and visceral portions of the aorta. So the left renal artery should be readily accessible and the celiac and superior mesenteric arteries may be mobilized by careful dissection. So the right renal artery is frequently difficult to isolate before aortotomy. So distally the iliacs are carefully exposed in the anterior avascular plane by gently mobilizing the overlying structures, especially the ureter, including the ureter. So again, the full exposure of the right iliac is typically more difficult by this retroperitoneal approach, depending upon the patient's habitus. So the extensive exposure of the supraceliac and visceral portions of the aorta permits the full access and decision making about clamp placement, and which may be suprarenal or supramesenteric or supraceliac can be done. So occlusive disease or aneurysmal involvement of renal or visceral vessels may be readily addressed by this approach. So once adequate exposure has been achieved, proximal and distal clamps may be placed as in the transperitoneal approach. Repair is typically accomplished by endoaneurysmography using end-to-end proximal and distal anastomosis to replace the diseased portion of the aorta as an interposition. So the same principles of back bleeding and flushing of the graft before completion of the distal anastomosis is same as in transperitoneal approach. So when hemostasis is achieved, the sac may again be closed over the graft, although the retroperitoneally placed graft is not as vulnerable to erosion or aortoduodenal fistula, because in transperitoneal approach, so the graft is overlaid by the second part of the duodenum directly, but here there won't be, so there is a less chance of erosion and aortoduodenal fistula because when compared to the transperitoneal approach. So in treating thoracoabdominal aneurysm, the incision may be extended into the chest at the appropriate rib space and the diaphragm circumferentially divided to offer the enough exposure to extend the repair to virtually any level of descending aorta. So medial visceral rotation introduced by Mattox or trauma and adopted to aortic reconstruction by Stoney is a thought technique that may, through an abdominal incision, afford exposure of the entire abdominal aorta. So the technique may be used for high paravisceral aneurysms and is best suited for patients who are not obese or ascetic with narrow costal margins and extending to the iliac crest. So next class we will be learning about how will you treat the ruptured aneurysms and what are the endovascular procedures and complications. Thank you.